Today's episode is brought to you by the Nuance Dragon Ambient Experience, or DAX for short. This is AI-powered ambient technology that helps physicians be more efficient and reduce clinical documentation burden. We have a lot of that, Kristen.
Sure do.
To learn more about how the DAX Copilot can help reduce burnout and restore the joy of practicing medicine, we got to restore that joy. Stick around after the episode or visit nuance.com/discover-DAX. That's nuance.com/discover-DAX. Knock, knock. Hi. Hello, everybody. Welcome to Knock, Knock, I. With me, your host, Dr. Glockenfleck, and I hope you had a wonderful day. I sure did. I'll tell you what my day was like. I was operating this morning. I did 11 cataract surgeries and 4 YAG lasers. Now, when I tell people those numbers, they're always like, whoa, that's a lot of surgery. And yeah, that probably seems like a lot of different surgeries to like a neurosurgeon or a vascular surgeon who could spend like 8 hours on one case or longer. In the world of ophthalmology, I would say it's like average day. And it was only a half day. I operated from 7:30 to about 11 out of one operating room and did 11 cases. But I know ophthalmologists who can do 30, sometimes even 40 cases in a day using multiple operating rooms. I honestly don't know how they do that. That's so much surgery. I mean, there's a lot of cataracts out there. You know, if you're over the age of 60, you guys probably know what I'm going to say. You have cataracts. Everybody on earth will get a cataract at some point in their life. So as with an aging population, there's a lot of cataracts out there, but my goodness, I feel kind of tired after 11 cases. Sometimes I'll do 12. I think the most I've ever done in one day is like 18. And so I don't know. That takes a level of stamina, and it's not so much like physically exhausting. It's just like it's always just a little stressful, right? So you got that, you're expending that kind of energy, like physical energy from like the stress of doing surgery on an eyeball on someone's eye. But also like the mental, you're doing so many cases and you want to make sure you have the right patient, the right lens, you have different devices you need for any, that's 20 different patients, 20 different eyes to keep all that straight. And it just, there is a lot of mental fatigue that can set in, and certainly after like 15 cases. But doing 40, like you're a machine if you can do that. And I know that some people do it. But I'll just to let you know, like how, you know, after 11 cases, I was ready. I was ready to be done because I came home and I took a nap. I do love naps, and I was planning it too. I was like, I don't have any meetings today. I'll be done at 11:30. My clinic in the afternoon doesn't start. I don't have to be there until 2 p.m. I took an hour and a half nap, everyone. I hope on the other end of this, you are applauding me. You are just fist pumping with me. Yes, he got a nap in. I think it's a win when somebody in healthcare gets a nap because we all work very hard. All right. We should celebrate the wins, everybody. You should, if you get to take a nap on a particular day, you should tell everyone you know, and we should all embrace it and congratulate each other for our naps. This is probably the most ophthalmologist type thing that you've probably heard me say, but it's true. All right, so I had a nap, went back. Had a great clinic in the afternoon, and I came home and I played with the kids, the dogs, and now I'm recording with you all. Had a nice dinner. It was just a good day. Not all the days are good, but this day was a good day. And I'm getting to finish it off here. I'm talking about something today that is that's in the news. We're talking about Ozempic because there was breaking news in ophthalmology. Actually, this came out like a couple weeks ago, but this is the first time I've had time to actually dig into it. We don't often have breaking news. Usually when we have breaking news in ophthalmology, it's, somebody found 27 contact lenses in their eye. Or turns out there's a cult and they're all using urine eye drops. Aged urine eye drops, in fact. It's like bad things. Or there's over-the-counter drops that are making people go blind. I had a conversation with a patient about that earlier. Which eye drop should we get? Stick with the brand names. It's always off-brand. It's always like kind of these weird, brands you've never heard of that I don't know, something happens and they end up getting Pseudomonas contamination and blinding people and sometimes killing people. So never heard it with the brands. Refresh, Sustain. I don't have any financial interest in any of these. I just tell patients all the time to use them. And until they give me a reason not to, I'm going to continue those recommendations. So anyway, but this is actually, this also is not great news. It's interesting. And the whole Ozempic story, and we're talking about Ozempic, Mounjaro, these GLP-1 medications for diabetes, for weight loss. They're just taking the world by storm. I have so many patients that come in because I see a lot of patients with diabetes, because every patient with diabetes is supposed to get their eye exam. So I will see them. And it's just, so I see all these patients and the amount of weight loss that they feel better on these medications is really remarkable. It's like some people don't tolerate them and then they have to get on a different medication. And then sometimes there's medication shortages. Like a patient the other day was unable to get Mounjaro because they ran out and had to get switched on to Ozempic, but they don't get as good of an effect with Ozempic. And the reason that the pharmacy ran out of Mounjaro is because too many people were getting it for like weight loss, but it was like really good for their diabetes. So I'm not an expert in these medications. I don't prescribe these medications. All right. That would be more in line with, probably primary care, endocrinology. Internists are probably much more familiar with this. I tend to stay away from oral medications because that goes to different parts of the body, sometimes the eye, but mostly not. So I stick with eye drops. So I don't know a lot about them, but I do know I'm seeing a lot of patients on them. So fast forward to like just about a week ago, I became aware of this study that was published in JAMA Ophthalmology. The study was led by Dr. Joseph Rizzo, MD. He's a neuro-ophthalmologist at Mass Eye and Ear, which is associated with Harvard Medical School. So one of the best ophthalmology places in the country. Just fantastic up in Boston. And so they had several of their doctors, just anecdotally, just as they're going about their day, notice, we are getting some patients, it seems like more patients with diabetes who are on Ozempic or Mounjaro, they're coming in with vision loss, with swollen optic nerves. It's kind of interesting. What is that? And that's how a lot of like these clinical studies start, is like, I think I'm seeing an association here. I think I'm seeing something going on. Let me study it. Let me look back and see if there's anything there. That's how a lot of these go, especially people who are still practicing clinical medicine. They kind of feel like there's a correlation, so they look into it. And they found some very exciting, very interesting findings. I'm going to get into those here shortly. Let's take a quick break, and I'll come back and we'll set this up for you. Okay, so the too long didn't read version of this is that it does appear that this study done by these researchers at Mass Eye and Ear showed that patients prescribed a semaglutide medication, Ozempic, Wegovy, I think Mounjaro is another one, for diabetes or weight loss have a higher risk of developing non-arteritic ischemic optic neuropathy, which is a potentially blinding eye condition. All right, so I'm going to explain. This is a good topic to do on this podcast. So we're going to talk about NAION, separate from the GLP-1 agonist medications, and then we'll come back to that at the end. So first, NAION, what is that? That's a lot of letters. We love our acronyms in ophthalmology. We're full of them. We love it. Well, I'm going to do something that ophthalmologists rarely do. I'm going to explain the acronym in detail, that you're going to know what this is. NAION, what is that? Non-arteritic ischemic optic neuropathy. So the most important part of it is ischemic optic neuropathy. It is what it sounds. So you have ischemia, blood loss to the optic nerve. So I'm going to take you on a tour of optic nerve anatomy. Are you as excited as I am? Oh, I am so thrilled about this. I hope you are too. So try to pay attention to the road while you're driving into work listening to this. All right, so the occipital lobe, we're going to go back to front. All right, so occipital lobe, that's where your vision cortex is. And so your vision neurons, all right, come into the optic nerve. We're going to go backwards. So we're going to start at the occipital lobe. Those neurons, they travel along the occipital lobe into the middle part of the brain, what we call the midbrain, where you'll find a structure called the thalamus. As part of the thalamus, you have this thing called the lateral geniculate body. So that's where all of the neurons that eventually go out to the occipital lobe, the back part of the brain, form this massive neuron cell bodies in the lateral geniculate body in the thalamus. And then from there, moving forward toward the eye, you have the optic tracts. So there's two of these. All right. So you have two lateral geniculate bodies, and then the neurons, now they're like kind of a big cable of neurons. Okay. So now they're real thick. They go along, and this is what's called the optic tract, forward toward the eye, eventually getting to the optic chiasm. So the optic chiasm, I'm not going to get too into detail, but there's nerve fibers that cross. Some of them go from the right side of the brain to the left side. Some of them go to the left side over to the right side. And it gets really complicated. And this is something that just frustrates med students who are learning this to no end. Like if you have a defect or some kind of stroke that affects part of the optic chiasm, where do you have your visual field deficits? And it's a whole thing. But anyway, so you have these nerve fibers that going from the thalamus along optic tracts all the way up to the chiasm. Some of them switch over to the other side, some of them don't. But they cross, so you have this like X thing, and then they go along the optic nerve to the eye. Okay? So when they get to the eye, that's what you can see. When you look at the back of a patient's eye, you can see a circular insertion of the optic nerve. That's the optic nerve. That's your physiologic blind spot because there's no photoreceptors. You don't see anything there, but you learn to filter it out. So it's sometimes you can find your physiologic blind spot, but it's not easy. And so anyway, that's where the optic nerve terminates. It terminates into the back of the eye. So going the other way, you have light coming into the eye. All the light signal, it brings, the photoreceptor sends signals. They all come together at the optic nerve head. That's the termination of the optic nerve right in the back of the eye. And then those signals going back the other way, they go along the optic nerve down to the chiasm. And then from the chiasm, they go along the optic tract to the thalamus and the midbrain, the middle of the brain. And then from there, they radiate out in the cortex to the back of the eye. That's very basic, the way vision signals get along the nerves and the central nervous system to the occipital lobe, to the vision cortex. So what we're going to focus on with this discussion is the optic nerve head, that place right where the optic nerve inserts into the back of the eye. because that is what's being damaged in an NAION. So you have an ischemic optic neuropathy, but it's non-arteritic. So what do we mean by there's arteritic and there's non-arteritic? Well, when we say arteritic, usually what we mean is it's an ischemic optic neuropathy that's caused by giant cell arteritis. It's a big, huge, terrible ischemia of the optic nerve. Non-arteritic is still a similar pathophysiology where you lose blood flow to the optic nerve head, that place where the optic nerve inserts into the back of the eye, but it's smaller blood vessels. This is a really delicate area because it's a small area, all right? That optic nerve head, when you look at the back of the eye, it's like a millimeter. That's a small area that all of those nerve fibers from your retina that are carrying that vision signal, all of them have to come together and squeeze through this tissue called the lamina cribrosa, because we have all kinds of funny words. Squeeze through that. Basically, it's like kind of the wall back there. Squeeze through that, and then the optic nerve continues on. But you got to squeeze it through. You got to squeeze it through. In that area, there's it's perfused by these little tiny blood vessels called posterior ciliary arteries. These short posterior ciliary arteries. So this is a very delicate area. That's the point, all right? In a non-arteritic ischemic optic neuropathy, you have a lack of blood flow through those short posterior ciliary arteries, the tiny arteries. Not the arteritic ischemic optic neuropathy. That's the big arteries. That's massive vision loss. We're talking non-arteritic, smaller blood vessels. And so this can happen for a number of different reasons. The most common reason this would happen is if the patient has a disease that already makes their little tiny blood vessels tenuous, not function quite right. Diabetes is the big one. High blood pressure is another one. Those are the two big ones. So the patients who are most likely to have this disease, NAION, are your patients with diabetes and hypertension. Because they're getting damage to the capillaries, the small blood vessels, those short posterior ciliary arteries that are perfusing the head of the optic nerve. And so when you have a temporary loss of blood flow because a patient has diabetes and they already kind of have problems with their blood vessels, it's kind of like a stroke. It's an infarction of a small part of the optic nerve. And so you end up with optic nerve swelling. And that's what we see. Patient comes in, they're like, oh, my vision's really blurry. Sometimes it's all of the vision. The whole vision is blurry. Sometimes it's only part of the vision. Maybe it's down below. They're like this area kind of below the equator that's all blurry. I don't see anything. Or maybe it's up top. It could be a segment. It could be the whole thing. But patients will notice a significant decline or change in their vision. And then they come in. I take a look. They got a swollen optic nerve because they lost blood flow. They have an infarction. That's what happens when you have an infarction, a stroke of the brain. The brain gets swollen because there's inflammation. The brain doesn't like not having blood flow. It gets swollen. Well, we just so happen to be able to see that in the back of the eye. We can actually see the brain swelling. That's what it is. It's optic nerve swelling. The optic nerve is part of the brain. And so it's unmistakable. We can see that. They've got a decline in their vision. And the thing is, it can be quite variable. Some patients just have a very minimal change in their vision. Maybe they go down to like 20/40 vision. Think of 20/20 as perfect vision, 20/40, 20/60, 20/80. Still pretty good vision, but a noticeable change. I've seen patients with NAION that have count fingers vision. All they can see is fingers counting in front of their face. So it can be quite severe, but it's still the same underlying pathophysiology. Now, there is one thing that can make this worse. I mentioned that you have all these nerves from the retina that are coming together to squeeze through the lamina cribrosa, squeeze out of the back of the eye through a tiny little area. Well, some patients have a larger area. Some patients have a smaller area. It's just how you're born. Some patients have a large optic nerve head, which means there's a much bigger area for these nerve fibers to leave the eye. Some patients have a really small area. They have a small optic nerve. It's really tiny. We call it a small cup to disc. Small area. All those nerves got to squeeze through a little tiny baby hole in the back of the eye. So now we can find ourselves in a situation where a patient has already kind of iffy blood vessels because of diabetes, and they have a small optic nerve. So now they're also they have bad blood vessels, but they're also trying to squeeze all these nerve fibers out of the eye, kind of squishing everything in there, which can lead to occlusion of these small blood vessels because it's trying to squeeze in there. So one of the risk factors for having an NAION is if you have a tiny little cup to disc. That's something we can see when we examine patients. So that's the classic example of someone who comes in with this disease is they're diabetic or they have high blood pressure or both. Usually they're in their 40s or 50s, 60s, somewhere in the 40s, 60 range, most classic. And they have a small optic nerve. Now, once you have this, does the vision get better? Well, there is typically, as the swelling resolves, because you have the initial insult, you have the initial lack of blood flow that will correct itself. These blood vessels have auto perfusion mechanisms that when they lose blood flow, they have the ability to relax and allow more blood flow to come in. So the optic nerve does reperfuse to a certain extent. And so the swelling in the optic nerve will go down, which can result in a little bit of improvement in the vision. But patients are almost always left with some degree of vision loss. And so they can be left with count fingers vision for the rest of their life. Sometimes I've seen them come back to 20/30, almost totally normal vision. And sometimes all patients are left with or the only defect they have in their vision is this tiny little area kind of up top or down below that they don't see. Otherwise, very functional. Won't be flying any fighter jets, but they're still got really good functional vision. So it's a pretty wide spectrum. So let's fast forward to this issue with Ozempic, Wegovy, GLP-1s. So all these neuro-ophthalmologists, God bless them, neuro-ophthalmologists, man, you can't find, where do they they're like unicorns. They really are. Like, where do they live? I guess in Boston. I don't know. We have like 2 or 3 in the Portland metro area. There's a lot of people here, and we only have a couple. Like, they're very specialized and they're very smart. Like, that's, as a complicated field, there's a lot of stuff going on with the eye and the brain and how they work together. And thank goodness we have them. I think they don't want to be found, because if they were too out there, they'd get us sending all kinds of stuff to them. But we have wonderful neuro-ophthalmologists here in Portland. So shout out to those. You know who you are. As if they're listening. I don't know. Maybe they are listening. Hi. Anyway. All right. So they're starting to notice, these neuro-ophthalmologists, man, these patients on Ozempic, it seems like we're getting more patients with NAION, and they looked back at it. So they did, this was the type of study here was a retrospective matched cohort study. So they used data from a centralized data registry of patients evaluated by neuro-ophthalmologists at Mass Eye over the course of like 6 years. And so they looked at just all kinds of patients, any patient that has had an NAION, basically. So a good number of patients, but, and this brings up the first kind of limitation of this study, is that NAION although in the neuro-ophthalmology world it's relatively common, it's not that common in the grand scheme of things. So you do have a relatively small number of patients, and so you're going to have an underpowered study, and that can make for volatile statistics. And so keep that in mind. NAION is really, I would say it's pretty uncommon, to be honest. But what they found is that semaglutide users with diabetes, after looking at all the patients that have had NAION, obviously most of them were not on this medication, but a lot of them were over 4 times more likely to develop NAION. 4 times more likely to develop that. And then overweight patients on Ozempic have a 7 times increased risk of NAION. These are pretty big numbers, to be honest. Like this is a kind of alarming. And the thing is, we don't know why. And it's kind of scary in a way because these medications have such a profound effect on blood sugar, on weight, and it's just, oh my God, they're blowing up. It's unbelievable. And then now we're going to start seeing some potential adverse events. Like I just feel like that's the way it goes. And in this circumstance, it's like, when you're going through FDA testing and everything, it's a rare enough thing in NAION that you might not pick that up, right, in your clinical trials. Plus, unless you have ophthalmologists involved, which we probably weren't, it's hard for non-ophthalmologists to wrap their head around some of this ophthalmology stuff. So it's a rare enough thing that you might not pick this up in clinical trials, but we're starting to see it now. And now keep in mind, this is pretty preliminary data. There's I mentioned limitations, that there's not a high number of people with this disease. The study population, by the way, also majority white, and overall pretty small numbers. And also it's a retrospective case review. So the researchers couldn't determine if the patients actually took their medication, if they were doing the right dosing, how long they were taking it, if they started it and then stopped it, or if they switched to a different medication. All of that could affect this, right? And so I want to make this perfectly clear. This study does not prove causality. There's no there's no causation here. It's not that Ozempic will cause an NAION. There's no data that suggests that. All right. And that's really important. That's really important because and that's why I went through that whole thing to tell you there are other factors here, other factors that predispose someone to having an NAION. Specifically, the reason that patients are on Ozempic in the first place. They have diabetes, they have vascular disease. So, but it's interesting enough, it's significant enough of a finding to warrant further thinking about this. All right. The old adage, we need future studies to examine these questions in a much larger and more diverse population. So anyway, I was really glad that they put this out there. You should check it out, JAMA Ophthalmology, if you want. And just because these are things that get conversations going, and hopefully other places around the country will start looking at this, because NAION it's not an easy disease to live with. I mean, you have this it happens in one eye typically, but patients that have an NAION where they lose vision, I've got a couple patients right now. One has a kind of a moderate, they're 20/80. They're still coming back from it. Another patient's count fingers. They just basically lost the vision in one eye. And what really sucks is because the underlying risk factors that lead to this are systemic. Diabetes and your anatomy, those small optic nerves. And if it happened in one eye, it can happen in the other eye. Bilateral, we call it bilateral sequential NAION. Pretty uncommon. If you have it in one eye, there's the studies I've seen, like 15 to 25% chance, somewhere around there, that the same thing will happen in the other eye. And that is devastating. It's awful. It's awful. Diabetes is just such a terrible disease that causes obviously lots of problems throughout the body, but in particular with vision. It's just so sad. Things like NAION, obviously diabetic retinopathy, we've talked about that on this podcast. And seeing a patient who's 30 have tractional retinal detachments, angle closure glaucoma from this disease, it's a hard one. And it's not the patient's fault, it never is. It's such a hard disease that now in this country, it's hard to get insulin. Sometimes it's cost prohibitive. And so that's why, like, one of the things that really grate on me is when I see people like complain about patients with diabetes not being not doing their medications like they were told, not being quote unquote compliant with their medication regimen. There's usually a reason, right? This is such a horrible disease that makes people feel terrible, that will take your vision, that will take your kidneys, that will take your heart. People don't just not do it. There's usually a reason, and there's so many different reasons. So it's just a bad disease, and I feel for people. And so it's wonderful that we have this new thing, right? GLP-1. I mean, this is why, because diabetes is such a difficult disease to treat and to control. That's why these medications are so just amazing. Like, what? Wow, we have a new thing, a new toy. We haven't had one in a while. Maybe it can prevent people from having to go on to insulin a little bit longer. But then, God, we start finding stuff like this. So, I don't know. More study, more research, but I definitely wanted to share it with you all because it's just something to think about. I would say, and I have never, until we know more about this, I'm not like telling patients they need to stop their medication, because it's a trade-off. Like, okay, the risk is higher. It's still a low risk that a patient is going to have an NAION. It's still, because it's still a rare thing that happens. It sucks when it happens, but it's still rare. And so you weigh that with the improvement in their general health, or their diabetic retinopathy, or just their diabetes in general, the improvement that they're having in their quality of life from taking these medications. Like, I'm not at the point where I would ever say, oh, your risk of NAION is too high. We need you to stop taking these medications. Not there. Not there. The research isn't there. But we'll know more. I'm sure we'll know more over the next year or so. So just fascinating stuff. So thank you all for listening. And that's all I have prepared for you. I didn't do don't do that eyeball tip of the week. Don't stop your Ozempic from just because you're afraid of having an NAION. Again, this is an uncommon disease. All right. I'm just in my little ophthalmology bubble, so we see all of them. But in the grand scheme of things, it's unlikely you're going to have this. All right. But I mean, you should be, if you have diabetes, you should be seeing an eye doctor anyway. And so you can talk about this. Hey, how are my optic nerves looking? Are they small? Do I have tiny optic nerves? I don't know. You can ask these questions. All right, ophthalmologists will be happy to talk to you about it. So don't just like panic and stop your medication, especially if it's working, if you like it, just because of this perceived risk. Because again, this is preliminary type of data. Next week, I'll have some, I'll go through, I didn't go through any YouTube comments, but you can watch this if you want to see what I look like I'm sure you've already seen me. I put my face everywhere on social media. You can go to my YouTube channel. It's one that's one for the podcast. So it's at Glockemfleckens on YouTube. You can check that out. Leave a comment. I like going through the YouTube comments on these because I get ideas for what I want to talk about. And you can also email me knockknockhi@human-content.com. I want to hear from you guys. What eyeball topics do you want me to talk about? I want to expose some grifting too. I love doing that. So if you come across an eyeball grifter, vision grifter, glasses grifter, any kind of thing that puts up your grifting antenna, let me know. Love to hear about it. I'll address it here. That's it. I'm your host, Will Flannery, Dr. Glockemflecken. Thanks to my producers, Rob Goldman, Aaron Corney, and Shanti Berg. I'm doing this by memory. I don't have it up. This is the first time I think I'm doing that. Our editor and engineer, Jason Portizo. Our music is by Omer Binsvi. See, I got this down. I don't need notes anymore. Knock Knock Hi, Knock Knock I is a human content production. We'll see you next time, everyone.
Knock knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.